We're okay. Everyone's still here. Your meal replacement drink, Your Highness. We made it.
Breaking news. We have been hit by a snowstorm, tragically leaving 27% of our brothers dead.
Cool sculpting eliminates fat cells.
Hello, ladies and gentlemen, dear partners and colleagues, and all our beloved friends. I'm Dr. Ting Song Lim, the Scientific Director for ADAC Kuala Lumpur 2020. It is indeed my pleasure to welcome all of you in ASEAN's first online aesthetic conference, ADAC KL 2020 Go Online. This year, we are glad that we managed to carry on with this conference despite the pandemic, which is still very serious in some part of the world. Last year, ADAC Kuala Lumpur 2019 was successfully held for the first time in Malaysia, and we were blessed with 70 world-renowned speakers and 515 delegates. This year, the pandemic did not stop us. Our theme for this year is the leap forward in Asian aesthetics. It shall feature up to 30 sessions presented by more than 80 world-renowned speakers and joined by more than 500 delegates. I'd like to take this opportunity to thank our generous sponsors. Diamond sponsor, Novo Nordisk, thank you. Gold sponsors, Menarini, thank you. Silver sponsors, Venus Medical, Elegant Malaysia, IDS Med, Zulik Pharma, Ilojo Asia, and BTL Industries. Thank you so much for your support. I would also like to express my gratitude to our producers, my friends, who have worked so hard to come up with interesting ideas for each session. Your support and contribution is crucial to our success. So before we start the session today, I would like to invite my scientific co-directors, Dr. Warapong and Dr. Rangsima. Dr. Warapong, are you here with me?
Hello, everybody. I am Warapong Manaskiati from Bangkok, Thailand. I would like to welcome all of you to our number 6 of ADAC conference. And this year is very first time that we having this online meeting. And I believe this is the very first online meeting in Asia on aesthetic dermatology. And the theme of our ADAC meeting this year is the leap forward in aesthetic dermatology. And this cannot be happen this year without the assistance of my co-director, which is Dr. Tim Song Lim from Malaysia and Dr. Langsima Wanipakdi Deisha from Bangkok, Thailand. And this year, we are having a lot of speakers internationally. The speaker that we have this year is almost 80 speakers that will cover the whole range topic of aesthetic dermatology. I am sure that you will enjoy it. So thanks again for joining us at ADAC KL 2020.
Of course, ADAC Kuala Lumpur 2020 won't be successful without our beautiful co-director, Dr. Rangsima. Dr. Rangsima, are you here with me?
My name is Dr. Rangsima Wanitpakdi Desha, a dermatologist from Thailand. I'm so proud to be part of ADAC KL this year as one of the scientific director. As you may know, that this is so uncommon situation because we are during pandemic situation. That is why the usual ADAC KL conference that used to be physical, interactive, and so much fun conference like last year, we decided to change it to virtual. But of course, we still want to make our motto like science, fact, and friendships. Also in this year, we will have at least 80 international speakers in our virtual conference, and we had more than 20 sessions from 20 producers. Hopefully we will have a very differentiated virtual conference. So much fun, so much knowledge, and of course still have science, fact, and friendship like our motto. I would like to again thank you everyone to be part of us. I know that this is going to be a hard time, but at least during this time we can enjoy the new knowledge and new information from all the market, and also new technology that might come around the corner. So we will be ready to get back up to where we were before the pandemic situations. Last but not least, I would like to also thank you, our sponsorship, which, there is many sponsors supporting us. Let me thank them, name them. Diamond sponsor like Novo Nordics, gold sponsor like Menarini, and silver sponsor including Allergan, BTL, Elojo Asia, IDS Med, Venusis, and also Sulik Pharma. Thank you all, and hopefully you all will enjoy the show as much as I do enjoy producing it for you. Thank you very much.
Thank you so much, Dr. Rangsima. It is so true that ADAC is all about science, fact, and friendship. And thank you both of you for bringing ADAC to Kuala Lumpur. So without taking much of your time, I'd like to welcome all of you again to ADAC Kuala Lumpur 2020 online, and do enjoy the show.
A very common misconception regarding botulinum toxin treatments is the simplicity of the procedure, which involves only few injections. Some say the outcomes achieved would be more or less consistent, regardless the skill or experience of the doctor. Do you agree? Hi, my name is Dr. Christy Moy, the host of these sessions, Refining the Art of Botulinum Toxin. First of all, I would like to introduce my co-host. Due to her long and hard to pronounce last name, she would prefer to be called Dr. Preeti. She is dermatologist and dermatologic surgeon in Department of Dermatology Faculty of Medicine Silira Hospital, Mahidol University. She is the one and only Dr. Rangsima.
Hi, Chrissy. Thank you for having me. I'm so excited. And I'm not only seeing all the panelists here, which is my good friends, and I'm also want to learn some new thing from our speaker today as well.
In these sessions, we are honored to have two speakers joining us to share their insights, techniques, tips and tricks of upper face and masseter neurotoxin injections. And we are very excited to have another two experts joining us for panel discussion after each topic. So stay with us and you are welcome to leave your questions below in the chat box and our experts will try their very best to answer them all. Most of our dynamic wrinkles occur on the upper face. Knowing in depth of upper face neurotoxin injection, I would say is the fundamental of botulinum toxin treatment. We are very honored to have our first speaker from United States. She is a board-certified surgeon who is fellowship trained in oculofacial plastic surgery. She is also a fellow of the American Academy of Cosmetic Surgery. She will be sharing with us her knowledge in upper face neuromodulations. Welcome, Dr. Sheila Barbarino.
Hi, Dr. Christie. Hi, Dr. Rasima. Thank you guys so much for having me. I'm so honored to be part of your conference. Tonight, I'm going to be talking about upper face neuromodulation. So first, we're going to talk about patient assessment for upper face neuromodulation. The first thing you really want to ask your patient is you want to know their history with neuromodulators. Have they had them done before? Have they ever had Botox or Xeomin, Dysport, whatever other names you guys have out there? You want to know if they've had browtosis in the past from it. Have they had a frozen face they weren't happy with? Do they get the Jack Nicholson brow? Does the left brow drop sometimes or the right brow drop sometimes? So the key to that is because you want to learn from other people's mistakes. You want to know what their muscles do when neuromodulators have been treated in the past so that you avoid all of those side effects or complications that made your patient unhappy so that you can have the best outcome. You want to know their desired outcome from the procedure. You want to know if they like a frozen face. Oftentimes, the younger patients really want no movement at all. I do think as you get older, to have a completely non-moving face looks very waxy and fake and weird. And so I often tell my patient and advise the older patients that, this is not the look you want. You want to relax your lines and not freeze them completely. You always want to take pictures of the patients while they're animating. You do this because in general, number one, you can see the before and afters and how great you've come and how far you've come. And number two, it's also, you can always learn from your mistakes and you can always get better. So looking at the pictures before and after, you can always get better. And oftentimes patients don't notice when they have one brow that's higher than the other or one brow that raises higher. And we've all seen it. People come in and they say, oh my gosh, this one brow never used to be like this. And then you will look at the before and after pictures and you look at the animated pictures and then you can really see that this is how they always were. And then they realize that with the neuromodulators, it can be balanced out. When you observe your patient, you want to really make sure you watch them move. Put down your piece of paper, hire a scribe. So what I do is, let's see this video of this patient. And this is exactly what I do in my office. I have them look at me and I have them scrunch in the middle and look angry. I have them make the bunny around their nasalis, using their nasalis, frontalis muscles raise up. Here you see the nasalis. Muscles you are trying to modulate. The procerus. The procerus is the one that everybody goes in for first. It's a deeper muscle. You want to make sure that you're nice and deep. The corrugator supercilii, the frontalis, the nasalis, and the orbicularis oculi. These are the 5 muscles that you will be treating when you're treating the upper face. Here are some tricks and tips for upper face neuromodulator. Don't overtreat them the first time. It's better to bring them back a week later and add more if you need it. Depth matters. Inject deeper in the muscle origin and more superficial in the insertion point. So that means that when you're treating with the deeper muscle origins, you're going to go really deep. And around the crow's feet, it's going to be almost like a TB test. It's going to be very superficial. Don't inject below the lowest dynamic wrinkle. When you inject laterally in the frontalis, you don't want to drop the brow and you don't want to cause them low brow position. treat the bunny lines to raise the medial brow, encourage the patient to treat the orbicularis oculi, to treat their crow's feet, but not only to treat their crow's feet and the wrinkles around the lateral periocular region, but also it lifts the brow. As we know, the orbicularis is a circular muscle, and as we release it, they get a nice lateral brow lift. In addition to that, I commonly treat the lower eyelid roll. Oftentimes in Asian patients, Hispanic patients, they have a very active orbicularis hypertrophy below that causes a eyelid roll in the bottom. And most of us really appreciate being treated there with neuromodulators. Be very careful in doing this with Caucasian patients with lower lid laxity or dry eye in old patients, because you can cause them to have ectropion and they can have extreme dry eye. Here's how I mark the patient in the upper face. So I traditionally don't actually mark my patient, but because we're doing a teaching lecture, I wanted to mark. So here is the procerus and the corrugators. I have them rise, and you always want to remember that the neuromodulator spreads about 1 millimeter around the area that you're injecting. So I have them smile, raise up, like I said, and you want to go in to the area of the muscle, the belly of the muscle. It's really going to relax that muscle without making it look awkward or weird. Neuromodulators, it's always a compromise. You don't get something for nothing. When you treat one area, it affects another. So you always want to make sure that you balance those muscles so you get a very seamless treatment. Here's my actual injection to the upper face. I'm treating her glabella first. So again, like I said, it's a very deep injection. I've switched over to 32 gauge needles. Patients love it. They don't feel anything or very little, and I get very little bruising and swelling, especially when you ice 10 minutes before. The more you ice before, the less bruising and swelling, as well as after. You know, patients always don't like the ice, but it really is the best thing for them. Here I'm treating the lateral frontalis, and like I said, don't go below the lowest wrinkle, so you don't drop their lateral brow. Here I'm treating the orbicularis. And again, we're gonna get that nice lateral lift as we release the orbicularis muscle. And I did treat her. You see how when she smiles, she gets that eyelid roll that really looks quite beautiful and relaxed and not as wrinkled after the neuromodulator kicks in. We treated the nasalis, otherwise known as the bunny lines. Here I'm treating the crow's feet again on the other side. And this is a very, very superficial injection. Thank you so much for having me. Thank you, Dr. Christie and Rasima, Dr. Rasima, and please email me with any questions. I love to keep in contact, especially all across the world. I have so many friends and I love interacting with all of you. Please follow me and like me on my social media, Dr. Barberino at Barberino Surgical Arts. Have a great evening. This is such a wonderful honor to be part of this fantastic group of colleagues.
Thank you, Dr. Sheila, for such an informative sharing. Now, let us move forward to the panel discussions to explore further in other aspects of upper face neurotoxin treatments. I have 3 experts with me, my co-host, Dr. Raksima from Thailand, Dr. Cheng Fang Wen, Medical Director of Taoyuan Milano Aesthetic Clinic, Taiwan, and Dr. Zinat, the President of Aesthetic Society of Bangladesh. Welcome you all to the panel. So, Dr. Raksima, can you comment on Dr. Sheila's techniques?
She did a very, very good job. You know, I love the way she talked to the patient first, see how patients express their facial expressions, identify problems, and then, you know, mark it out right before. So which means she will correct all the dislikes and concern to the patients.
Dr. Chen, who you would not recommend neurotoxin injection for upper face?
Actually, I believe most of the people, or most of the patients, they would benefit somehow from upper face neuromodulation. But in choosing patients, I am indeed more picky when it comes to forehead lines treatment. I often reject forehead toxin to some of the patients, especially when I see more droopy upper eyelids, and especially when the patient is constantly raising their eyebrows to compensate for the droopy upper eyelids. For those patients, if you use higher doses of botulinum toxin, you would cause ptosis. They would look very sleepy and very tired. So that is the indication I think that's most challenging in the upper face. But other than that, the glabellar lines, the lateral canthal lines, I believe most patients would benefit from those treatments.
I would like to ask Fang Wen your idea, because what you mentioned is very, very good point. Is there any age limit for you, and also Zinat, if you want to join? Is there any age limit that you will not overdo forehead toxins?
Actually, I believe how the patient use their eyebrows or use their frontalis is more important than the actual age. I treated patients 70 years old who with forehead lines, but not that bad compensation, and she had a good result without ptosis. And I've also seen patients 30-something, but she was already constantly raising her eyebrows to compensate for the droopy eyelid. And that was years ago. I didn't know better, so I treated her frontalis, and she looked very sleepy for like 1 or 2 months.
So do you use different doses in different gender?
Firstly, we have to know that the male brows are a little lower down on the orbital rim. So we have to be very careful in placing our product, because if we place it on the brow, it may be little down on the orbicularis oculi. So we have to really palpate the orbital rim first and then place the product. And the male patients, depending on, actually we see that the patients of mixed ancestry, like the Métis patients and the patients and the Asian patients, I tend to get a lot of patients who have very chubby face, whose skins are very thick. So in those cases, we may have to use 1 or 2 or 3 units more than the Caucasian patients. So, Seema, what do you think?
For me, I think it's not related to sex. So,
it's not related to sex. It's related to the race. Yeah.
Yeah. So, some of the speaker might say, like, they inject more in male, or some may say inject more in female because, like, male, you need to keep some lines. But for me, I think it depends on, like, the severity and how the patient would like to get the result. So, in male patients, sometimes the muscle is stronger. Actually, you may need higher dose of toxin. But,
yes.
But for males, sometimes you need to keep the look of having some fine lines.
Yeah.
So I think that you need to wait between that, and pre-consultation will really help to get the result. And for me, I think male is a bit more challenge. I suggest you all to just, like, you try to inject like 70 to 80% of the expected dose first, and then ask them to come back for touch-up, especially for the first session of you and that patient.
How about combination treatment? Do you often combine other treatments with neurotoxin in the same setting? If yes, what is your favorite treatment to combine with?
That would be the preferred treatment plan if I can choose, if the patient agrees. Yeah, Toxin is one of our tools, one of our weapons. It gives us some results, but it's usually not enough if we want a holistic rejuvenation to a patient. So ideally, we can combine fillers, we can combine energy-based devices to treat not only the upper face, but also the entire face. You would need to reconstruct the volume that's lost, the support that's lost with filler or fat or biostimulators. You will need to tighten the skin, the soft tissue envelope with energy-based devices, and also you will need the botulinum toxin to help you to reduce the dynamic lines. So ideally, I would combine all those treatments, but with one exception. If the patient received forehead fillers, to like 3, 4, 5 syringes of fillers to the forehead, and that usually leads to more swelling. And during that session, if we treat like the glabellar front lines, it would be more risky. You would risk more dislocation or diffusion of the toxin to the unwanted muscles. So if possible, I would treat the frontalis and the glabellar front lines 1 or 2 weeks before filling the forehead. It would be safer.
Sometimes we also combine energy-based device. So, and the question and concern is like toxin is very sensitive to heat. There is already publication on that. If you even do the energy-based device over the toxins area, it won't how we say, denature the toxin. The efficacy will be the same. But for me, I'll just better to be safe than sorry. If I were to do a combination with energy-based device and toxin, I'll do energy-based device first and then toxin afterwards. And sometimes even it's safe from the temperature rising, but moving or touching the face after you inject toxin might create more of the massaging effects, and then it's spread. So I think if you want to do in the same session, do energy-based device first and toxin afterwards.
What about doing in the same sitting neuromodulators as well as fillers in the same sitting? What is your opinion about that? Do you think it has an advantage over doing it in 2 separate sessions? Because they say that if you do fillers and neuromodulators in 1 session, then you get a longer longevity of the fillers and the Botox. Is that true? What is your experience regarding that?
I think it's not like you need to do it in the same session, but you combine it, but you can sequentially do it. You can do toxin first and then wait for the effects to kick in. And then, after you relax some muscles and then you ask the patient to come back for fillers, you may experience using less amount of fillers afterwards because it's already improved. But for me, to be safe, you just don't treat the same area together. If you are doing upper face toxin, you do fillers like lower face. And then you can just ask the patient to come back for touch-up. Divided into different sessions might be safer.
Okay, yeah, I do that. But I was reading up on this different thing, on the longevity affair. Okay, thank you.
Thank you all, and take a break for now. Let's move on to the lower face. Our second speaker is worldwide known dermatologic surgeon from Israel with a special expertise in non-surgical methods of facial rejuvenation. She had published more than 80 scientific articles in leading dermatologic journals and textbooks. She is definitely a devoted teacher and mentor. Welcome, Dr. Marina Lundahl.
It's my pleasure to present my experience with masseter injections for aesthetic purposes. Should we do it or not, and how to perform it? I'm Marina Lundahl. I'm a dermatologist from Israel. And it's a pleasure to be here with you in these unusual times of corona pandemics. And I hope that all of you are well and healthy. So what are the major indications to inject masseter muscle? Basically, there are 2 indications, a group of aesthetic medications for masseter hypertrophy, aiming facial harmonization, and the other indication is to improve functionality, basically to treat bruxism and teeth grinding. In this case, we inject not only masseter, but also temporalis muscle, and I'm not going to discuss this indication in my current presentation. For facial harmonization, who is the ideal candidate? Based on my experience and what I observed from Asia, I think there are actually two major aesthetic indications. For Asian faces, it's for facial slimming, because Asian faces are usually heavier than Caucasian. In Caucasian, the indication is almost the opposite. We treat masseter in more masculine faces to make them more feminine. And I think that the two examples that you see on the current slide actually demonstrate this indication quite nicely. I will present the model that I treated in life. We will follow up the results, and we will discuss how it should be performed and what our target should be. So our model is 42 years old lady with a little bit of masculine look, and she does not have any bruxism. When I asked her about temporal joint pain, or when I checked her teeth, no grinding of the teeth was found. Look at her face at rest and as she clenches the teeth, and you really can get the impression of masseter hypertrophy. It's a big muscle which makes her face a little bit too triangular, especially the lower part of the face where masseter is located. So she is a good candidate for this treatment. What are the dosing for masseter injection for this indication? And since we have currently different botulinum toxins, I will refer to each of them separately. When we are talking about Botox, botulinum toxin, the reported dose ranges between 100 to 300 units per side. It is a big dose. When we are talking on a botulinum toxin, which is Botox, is between 25 to 100 units. And for Inco or Xeomin, it's 40 units per side. Looking at the literature, usually higher doses are recommended for Asian faces. And again, I want to make one point here. Masseter injection is unregistered indication. So when we do this treatment, we do it off-label. There is at least one publication a few years back which was trying to individualize the dose according to the bulging type, and the authors of this publication classified the bulging to 4 separate types with different severities, as you can see here, and we really can see that the bulging has a different shape in some patients, and we can see, for example, in type 3 that we have 2 bulges, it's not a single bulge. So we can accommodate the dose and the injection pattern according to the specific bulging type. So this is the tailored botulinum toxin type A injection protocol according to this publication. As you can see, there are bulging types for 1 to 5, and there is a thickness, estimated thickness of the muscle, and they classify it from mild, moderate, and severe. And according to the types, the dose is tailored. To inject masseter, we have to be cognizant with the relevant anatomy of this area. And this is the relevant anatomy. You see the green structure is parotid gland, which overlaps partially the lateral part of masseter. Another important structure is in the anterior part of the masseter. This is a risorius muscle which precipitates in a smile. So to inject masseter safely, we need to define a safe zone. And this is how safe zone is defined. You see different suggestions, but basically we draw a line. The way I do it, I draw a line from the mouse corner to the tragus. My injections are below this line, and then I'm trying, when I ask the patient to clench the teeth, and I really palpate the muscle and I mark the anterior and the posterior part. So anterior part should be marked to avoid affecting the risorius muscle. Posterior part should be marked to avoid or to minimize the effect on the parotis muscle, on the parotis gland, sorry. So this is how I perform the markings. This is the line from the mouse corner to the tragus. And then I ask the patient to clench. And you see, we can really palpate and see the muscle. Again, we're talking on patients with masseter hypertrophy. So it's enlarged muscle. So when they clench, you can really see and feel the muscle. If you don't, it might be not the right patient for the injection. What I marked in addition is the upper lobe and the lower part of the masseter. The masseter is trapezius-like shape muscle, so it is a little bit thinner in the upper part and a little bit bigger in the lower part. So those are my markings. How I perform the injections. I inject deeply, as you can see here, but I inject along the muscle. When I retract the needle, you can see that I keep injecting. So I deliver two doses in the lower part and one dose in the upper part. And why it is important to inject along the course of the muscle, we will discuss a little bit later. When do we see the initial results? It usually takes a little bit longer than in mimetic muscles. When we treat mimetic muscles, usually the results are seen in 1 week. For skeletal muscles, don't forget masseter is skeletal muscle. The results are a little bit more delayed. So we see the results in 2 to 3 weeks. And it's important, first of all, we need to inform the patients so they should know when to expect the results. And in addition, it's important when we should call the patient in. And I always invite the patient for follow-up session after 3 weeks, especially the patients who are treated for the first time. The reduction of the volume is visible already on week 3, but it continues to be more and more visible with maximum volume reduction in 3 months, and usually the effect lasts 6 months. So in Caucasian patients, it's 2 times a year treatment. For Asians, there is a different approach. Sometimes they're treated every 2 months to create really a reduction of a masseter muscle, and this can last longer. So let's see the result in our patient, Caucasian lady, and you can see her before and 4 weeks later in rest and as she clenches. And I think that in overall, the face looks much less masculine, a little more feminine currently, both in rest and as she clenches her teeth. And if we try to measure, we can really see a reduction in the volume of the masseter muscle as she clenches. And this is from Asian patients. This is a different type of injection. It's continuous, it's multiple injections until you get the right volume. So usually it requires 2 or 3 successive sessions to achieve this kind of results. This is another published case. Again, it's a Caucasian patient, and you see that the effect in Caucasian patient is achieved after a single treatment. What can get wrong? What are the potential complications? Overall, it's quite a safe treatment, as in almost any injection of botulinum toxin, injection site complications such as bruising, hematoma, a little bit of local focal sensitivity. They are normal and expected. Headaches can occur in following masseter injections as well. Paradoxical bulging. It looks very, very strange. Why? When we inject masseter instead of miniaturization of the muscle, in some patients we see this paradoxical bulging. And the explanation of this phenomenon is based on the anatomy, because there is a tendon which divides the masseter muscle to deeper and more superficial fibers, and this tendon is actually blocks toxin diffusion. So if you inject deeply only, the superficial fibers of the masseter muscle are not addressed. So when the patient clenches, they contract. And this is why we see this paradoxical bulging. And we can see it here, the superficial part of the masseter muscle. If it is not treated or undertreated, it will bulge on clenching. So again, just to see carefully how I do the injection, you see I start deeply, but I keep injecting as I retract the needle. So I am completely confident that both the deep part and the superficial part of the masseter muscle are addressed. If you have the bulging, how it should be corrected, we need to add some botulinum toxin superficially to address the superficial belly of masseter. If you again inject deeply, you do not correct the paradoxical bulging. It bulges because the superficial fibers are not addressed. Another adverse effect is dry mouth or xerostomia. The reported incidence ranges between 6 to 13% in different publications. And again, it is due to the malfunction of the parotid gland. So let's look again at the anatomy. So if we inject masseter a little bit too lateral, we will affect parotid gland, which is the gland that gives the saliva to the mouth. This parotid gland is innervated by acetylcholine, so it is affected by botulinum toxin. So if we inject too lateral, if we do not respect the safety zone, xerostomia can occur. Usually it recovers spontaneously in 3 to 4 weeks, but if it is very severe, there is a publication in which pilocarpine tablets were suggested as the treatment to the dry mouth induced by masseter, botulinum toxin injection to masseter. Pilocarpine tablets are usually 60 milligrams, and 3 doses daily are needed, and it's considered to be quite a safe medication. So if the patient suffers of the dry mouth, this treatment can be considered. Smile asymmetry is another potential complication of masseter treatment, and it is due to the diffusion to the risorius muscle. Again, just remember the anatomy. Risorius muscle lies anteriorly to masseter, a little bit more medial, and this is the patient in which the left risorius does not function. So as she smiles, we see the asymmetrical smile. And I just wanted to show you, because there's some very similar, but not quite the same complication can occur as we inject botulinum toxin to ground feet, and we inject too low, and then the affect zygomatic muscle. Again, it will create asymmetrical smile, but it looks a little bit different. I will play the video again, so you can see the difference between the risorius muscle action and zygomatic muscle action. So it's a symmetrical smile in both circumstances, but it's a little bit of different asymmetry. Unfortunately, there is no real good treatment for this adverse effect, and we just need to suggest our patient to wait, because it resolves spontaneously. If it is quite severe, you can consider to do the same on the other side, because face symmetry is very important. When the patients are asymmetrical due to other treatment, they feel very bad. So sometimes to affect both sides, but to resume symmetry can be considered. in the last year, there was some publication which actually questions the ethics of masseter injection for aesthetic purposes, because based on this publication, it seems that when we inject masseter, we impair the bone quality of the jaw. This is a study in animals, in mice and rabbits, and they showed that by injecting botulinum toxin to masseter, mandibular condyle getting osteoporotic. It affects the teeth. We need to investigate the issue, because in some countries, for example, in Russia, currently they advise not to inject masseter for aesthetic purposes only. When it's a functional thing, bruxism, you can, it might worse even if it causes some kind of osteoporosis. For aesthetic purposes, it might be questioned in the future. And again, osteopenia caused by botulinum toxin injection to masseter. It was a pilot study, 7 patients injected here for temporomandibular joint disorder. So they did have functional reason to be injected. And what they showed on CT, that there are some changes reflecting osteopenia. So we have to remember, and we have to learn more about this topic, whether our masseter injection can affect the quality of the bone, and what are the consequences of this adverse effect. Again, another study, both of them showing the same. We reduce the muscle thickness, but we also affect the bone volume of mandible. So I think that by that I finish my presentation on masseter injection, the indication, how to do it, and should we do it. And I hope that in the near future we get more answer to my last question.
Thank you so much, Dr. Marina Landau. It is indeed a very comprehensive and thorough explanation from indications, dosage, marking, as well as the techniques and the possible complications. So now please welcome back our experts, Dr. Raksima, Dr. Zheng, and Dr. Zinat for panel discussion. Hello. Let's throw the first question to Dr. Raksima. What is the most common side effect or complication you ever encountered, and how can we avoid it?
For me, I think when you inject it too anterior, so, sometimes the doctors trying to get the whole muscles paralyzed, because when you clench, you can feel the anterior border of masseters here, and then you trying to get it like overall, and then sometimes it's get spreading anteriorly, and it hit rhizorius, and it will cause the facial asymmetry or weird facial expressions, especially like for the muscles that control the mouth. So I think that might be the main pitfall for this. My technique is I'm go over like maybe even 50% on the backside, posteriorly, just to keep it like that first, especially in the first session for the patient, because reducing it 50%, backward, is more than enough to contouring the face. I think that is one point. My second point is you need to really go deep enough, because masseter has a very thick, and then there is 3 layers of it. If you hit just only superficial part, it won't get the whole muscles paralyzed. And when the patient trying to clench, there will be compensation, and you see like a fish gill when they clench, which is not look so good. I think that is the area. That is why marking and feel the muscle is really important in injecting this area.
How about Dr. Zinat? Is masseter botulinum toxin injection very common in your practice?
Not very common, but it's, I won't say it's very uncommon also. And looking at Dr. Landau's presentation, it was wonderfully shown that when you inject the masseter, as you inject and as you are coming out, you should keep on injecting, because the superficial belly gets left out, and then you are left with the paradoxical swelling. So in my practice, the young male, the metrosexual male who are very conscious of their looks, if they have a very wide mandible, and if that makes them look very fat, maybe they are thin, but their face is very big, so they come for that.
One thing I would like to add on is, like Sinat said, getting a very good interval and also selecting the good patient candidates. In some of the patients who start having laxity on the jawline, sometimes you weakening the muscle too much, make the jaw or laxity worse. They look even older, even they get a slim face. And when you age, sometimes you need to really keep the shape of the face there. And masseter is one of the structure that can keep the jawline contour look so good.
I do agree with Dr. Zina and Dr. Rosima. And what is interesting is that I found some doctors or even some patients, they would somehow perceive the target of masseter neuromodulation to be eradication of the masseter muscle. When we palpate the masseter, we always ask patients to clench. So sometimes patients will come back and doing this and say, how can I still feel my masseter muscle moving? I would say that's normal, because we are not going to peel off your entire masseter. We are just trying to contour it to what is just right for your entire lower face. So you don't really need a very high dosage to take it out.
In that case, Dr. Chung, do you very often inject masseter for male patients? Will masseter botulinum toxin for men causing feminizations?
I do it very often, and I don't see feminization in my male patients. That's interesting, because when we talk about male aesthetics, we often say that a squared jaw is a more masculine feature. But interestingly, at least in Asian patients or in Taiwanese, Chinese patients, I don't see that a slimmer lower face make them look more feminine. If it's a more chubby man with more ample subcutaneous soft tissue, a squared jaw bulging like this, it's not actually masculinization. It actually reminds you of the look of a chipmunk. It actually looks childish. And so you can imagine the benefit of reducing the masseter in those kind of patients. And in the other kind of slimmer male patients with a sunken, hollowed cheek and a very sharp angles to the mandibular angle, that's masculine, but that also looks more aggressive. So usually if you reduce this angle a bit, he looks actually more gentle, looks more friendly. So in properly selected patients, I don't see feminization of male patients after masseter reduction.
I think you can show your jawline that you look so good. And I think the good combination of it is, sometimes reducing the size of masseter a bit along with fillers injection. Yes. To create the sharp demarcation of jawline. That will be the perfect combination.
Yes, it is very true. Forget about the golden ratio, masculinization or feminization rules. Each individual are unique and not every single patient fit into the certain rules. We should customize and tailor a treatment individually. So come to the end of the session. If you would like to give one piece of advice to our delegates about neurotoxin treatment, what would that be? Maybe we can start with Dr. Rangsima.
I think everyone thinks that injecting neurotoxin is easy because it has been with us around 20 years already, like my marriage. You know that you think that you know everything about your husband, but you might not know. For me, I think you need to realize, how you use neuromodulator as your, as your tools. Don't overdo it, don't underdo it, and, mix and match. tailor-made with each individual patient. Even you treated the same patient, but when times change, over time, you may need to increase or reduce the dose if needed. It's not a fixed protocol, but you really need to adapt and change it because facial expression sometimes change with age. And most of the time, you need neuromodulators to combine with any other tools that you have. It's more like the special ingredients in your marriage life.
Wow, Dr. Roxima, such a good analogy using marriage to relate with neurotoxin. How about Dr. Zheng?
Don't inject by the books. You do have to observe and to talk to the patients. The wrinkles are always different from patient to patient. And even if you feel that the wrinkles, like the frown lines in these two patients, they look very alike, you might inject differently because of their different preferences, because how they like to preserve the motion of their brows when they make facial expressions, or they don't like the tiny lines in the middle part of their upper eyelids, things like that. That would you have to tailor your injection to meet each individual patient's need. That's how we can achieve high patient satisfaction.
Yeah, very good point, Dr. Zheng.
I would like to, quote Dr. Stephen Diane, who believes that there is a special theory of relativity for attractiveness. Actually, when we do the neuromodulators for face, they have been around for a long time. We should respect the patients. When we counsel the patients, we should respect the patient's desires as well as patient's age. There are so many patients who are in their middle age who wouldn't like to erase all that had happened to them in their lives. Like they had their face reflects a lot of happiness which they experienced before. They had a lot of amount of sadness, they had a lot of amount of stress. They don't want to erase totally that they experienced throughout their lives. So I get some patients in their 50s who come to me to get a refreshed look. So for them, I do a little bit of, like Dr. Rumsima said, a little bit of adjunct with the neurofillers, with the neuromodulators. That is, I give a little bit of meso Botox, like I add a little bit of neuromodulator fillers with diluted neuromodulators, and that gives them a refreshed look. And but they still have their wrinkles. They don't want to look artificial or fake. So this is with the little bit of older patients. And with the younger patients, we have to really see what they want. If they really want to have a frozen look, we as doctors, we try to maybe not discourage, but tell them that okay, if you have that look, people will point fingers at you, or you will not look natural. So for younger patients, it's very easy because they are the ideal patients. They don't mind any bruising, they don't mind any asymmetry. They come back to you, they're open. So with the younger patients, it's very easy to deal. With the older patients, it's little difficult, and we have to customize according to their age and according to their wishes.
Thank you, Dr. Zinat, for your advice. I really hope that we have more time to continue our discussion. Unfortunately, we have only 1 hour for this session. I hope you gain some ideas and tips to apply in your practice. Thank you once again, Dr. Rangsima, Dr. Zheng, and Dr. Zinat for such an insightful sharing and guidance. If you have questions related to this topic, feel free to drop your questions in the chat box, and our experts will answer them as soon as possible. Thank you for joining this session, Refining the Art of Botulinum Toxin. I am your host, Christy Moy. Don't go away. There are more interesting topics after this. Stay tuned.